Hello, everybody, and welcome back to Emergency Medicine Quest. In today's video, we will be discussing pleural disorders, namely pneumothorax and pleural effusion. Before we continue, make sure to like, share, and subscribe to the channel for more such content. Starting off with pneumothorax. So, we know by definition that it is an abnormal collection of air in the pleural space. Now, it can be either primary, secondary, or tension pneumothorax. Primary in one line is basically when a pneumothorax occurs spontaneously in absence of any risk factors or precipitating factors, and the patient is usually not having any underlying pulmonary disease. In secondary, they will have some form of underlying pulmonary disease. Tension pneumothorax, on the other side, is a life threatening sort of pneumothorax with displacement of mediastinum and hemodynamic compromise. Generally, we see that the primary pneumothorax occurs in young and healthy people, more in men than in women. It can also occur in people those who have Marfan syndrome. Secondary normally occurs if they have a diseased lung, so they should have an underlying disease like COPD, TB, HIV, etc. The clinical features of spontaneous primary or secondary is generally ipsilateral chest pain with some dyspnea. In terms of the vitals, you will see them being sinus tachycardic. If the pneumothorax is huge, then they can also have hypoxia, hyperresonance, absent tactile fremitus. But obviously, the absence of any of these signs does not rule out pneumothorax. As for tension pneumothorax, they can have hypoxia, they can have increased work of breathing, they can have sinus tachycardia, they can be hypotensive, they can have jugular venous distension, tracheal displacement, and they can also present in cardiac arrest. We diagnose these patients, although their history in the physical examination can be very suggestive, but if we're suspecting, then we can go for a chest x-ray. The chest x-ray, as we can see over here, will show us these radiolucent areas that does not have any lung marking. Now, there are different ways that we can measure a pneumothorax. So there is the American way and there is the British way. In the American way, what we do is basically we measure, so it's marked here by A, we measure from the apex to the cupola. Okay, so this distance, it has to be less than 3 centimeter for it to be considered small. Anything bigger than that is considered big. On the other side, the British look at the hilum. So you look at where the hilum is. Let's say the hilum is over here. Corresponding to that, you will measure the intrapleural distance marked here with B. Anything less than 2 centimeter for the British guideline is considered small. Anything more than that is considered big. In tension pneumothorax, there will be usually a complete lung collapse with mediastinal shift. There's also something called as sulcus sign. So sulcus sign is basically a very deep claustrophrenic angle sulcus that can indicate the presence of pneumothorax. Sometimes this is the only sign that the radiographers rely on to diagnose pneumothorax, especially if the lung is very diseased. When the diagnosis is unclear, we should consider CT to evaluate these patients. So generally, chest CT should be considered in two scenarios. Number one, if the patient has significant lung disease and they're presenting with hypoxia, dyspnea, or you have a non-diagnostic chest x-ray in a patient with dyspnea and hypoxia. The type of CT that we go for is a non-contra CT. The third imaging modality that we can use is ultrasound. Now, it is said that the sensitivity of chest x ray is from 28 to 52%, but for ultrasound, it's higher from 90 to 79 to 92%, ranging on the operator use. Obviously, for this, we have to use the linear probe, and we look at three things basically on the ultrasound, and we ask ourselves this: is there any lung sliding? Is there any lung point? Do you see any barcode sign in M mode of the ultrasound? The management of pneumothorax is basically dependent on two principles. One is to evacuate air from the pleural space, and the second is to prevent recurrence. So let's divide the management into primary, secondary, and then depending on what is the size and how significant are the symptoms. So starting off with primary pneumothorax, that is small in size or the patient has minimal symptoms. Now here what we can do is give them oxygen, or we can choose to observe them. The rate of intrinsic absorption of pneumothorax on itself is 1 to 2% per day, which can be basically augmented if we give them 100% oxygen through non-rebreather. If we decide to observe them, then we have to observe them for at least 4 hours and repeat a chest x-ray. If the pneumothorax is still primary, but it is large in size and is causing significant symptoms to the patient, then we have three options. Then we have needle aspiration, we have chest tube, and we have the option of observation. Now, in needle aspiration, we are basically going to introduce the needle in either of the two places, either in the second intercostal space, mid clavicular, or in the fourth intercostal space, anterior axillary. If needle aspiration fails, then we move on to basically chest tube. So we insert 8 to 14 French of chest tube using a Seldinger technique. In moderate to large pneumothorax, observation is not a bad idea as well, especially since recent studies have shown that it is non-inferior to drainage in uncomplicated cases of pneumothorax. Moving on to secondary, so we can again divide the management into two categories, either small in size or minimal symptoms, or large in size and significant symptoms. Here, if it is small in size, then we have the option of observation, but we have to observe them for at least 24 hours, or preferably we admit them. This is because there is a very high likelihood that the pneumothorax is not going to be absorbed at the rate we want it to be. If it is large in size, then we can consider doing needle aspiration, and if it fails, or if the pneumothorax does not decrease in size or does not confer significant improvement in symptoms, then once again we opt for the chest tube. But in either cases, there is no question of discharging them. In both cases, they will get admitted. Obviously, in cases of tension pneumothorax, we have to see how hemodynamically compromised the patient is. If the patient is severely hemodynamically compromised to the point of arrest, then we have to do needle decompression. But obviously, remember that it is only a temporizing measure, and so after the needle, we insert tube thoracostomy, which is the definitive management of tension pneumothorax. Pleural effusion is exactly what pneumothorax is, except in space of air, it's gonna have fluid. So it's abnormal fluid collection in the pleural space, and we can divide it into two groups. We can divide it into transudate and exudate. Transudate is basically this fluid that is ultrafiltrate of plasma, and that is why it has very less amounts of protein. Some of the common causes of transudative is congestive heart failure, liver cirrhosis, nephrotic syndrome, or severe malnutrition. In cases of exudate, there's a difference because there will be very high amount of protein in the fluid, and it can be either because of a parapneumonic effusion or a malignant effusion. Now, bear in mind that when a patient comes to you clinically, there might be features that will cause the patient to overlap in transudative and exudative effusion. And this is basically because the patient can have multifactorial pathology. Regardless of the type of effusion they present with, they are going to come to complaining of pleuritic chest pain with dyspnea, decreased breath sounds, dullness to percussion, and decreased tactile fremitus. To diagnose someone with pleural effusion, there are many modalities available, mainly in the imaging area. So, we have chest x ray, which can detect as less as about 200 mils of fluid, and we will see as the area circled in the picture blunting of the claustrophrenic angle. Generally, we have to use a frontal chest x-ray because it's very difficult to see pleural fluid on a supine chest x-ray. The other imaging modality we have is CT, which detects around 3 to 5 mils of fluid. But again, to do CT for each and every patient with pleural effusion is not feasible. And finally, something that's more readily available, cheaper, and less radiation to the patient is ultrasound. Obviously, ultrasound is more sensitive than chest x ray at estimating the size of the pleural effusion, so it can find out about 50 mils of fluid. Ultrasound is great because it can also help with tube thoracostomy for landmark marking. Now, most patients with pleural effusion should undergo diagnostic thoracentesis to determine what is the cause of the fluid. That means, is it transudative or is it exudative? By this, obviously, not all thoracentesis needs to occur in the emergency department, but if a patient needs urgent symptomatic relief, then it can be performed in the ED. Now we have a criteria at hand that differentiates between transudative and exudative effusion, which is called this, basically Light's criteria. As per Light's criteria, we have three things. We look at pleural fluid protein and serum protein ratio. If it's less than 0.5, it's going with transudative. More than that, it's going with exudative. Pleural LDH and serum LDH values, if the ratio is more than 0.6, it goes with exudate. Less than that, less than 0.6, it goes with transudate. And if the pleural LDH is less than 2/3, so the value itself is less than 2/3 of the serum LDH, then it goes with transudative, otherwise exudative. The thing is, any one of these criteria present can make the fluid exudative in nature, but for transudate, all the three criteria has to be met. Now, the management of pleural effusion is relatively simple. If it's a massive pleural effusion, that means if the fluid estimation is around 1.5 to 2 liter and the patient needs urgent symptomatic management, then we have to do urgent thoracentesis. We have to be aware before doing a thoracentesis about relative contraindication and complications. So, relative contraindication is if the patient has got any coagulopathy or has got any bleeding disorders, if the patient has any chest wall infection. As for the complication, so it's very important that after we do the thoracentesis, we have to do chest x-ray or repeat ultrasound to evaluate for these complications. So what are these complications that we can have pneumo or even hemothorax. This is the one that we are most concerned about, and then we can have other things like lung laceration, shearing of the catheter tip, and so on. This brings us to the end of the video.